When we started our group, with the encouragement and enthusiasm of yourself and Rose, were you optimistic? And do you feel that your efforts were worthwhile? We started nearly 2 years ago with 23 members, and we are now well over 100. I should think we must be 110 after tonight. We believe that about 450 men are diagnosed with prostate cancer at the Churchill each year. Our membership has grown by 40 per year. That is to say, 10% of those diagnosed. Should we be satisfied with that, or do you have any suggestions to increase the numbers?
Firstly, I'd like to say I think it's absolutely fantastic what the group has achieved. We've got some fantastic committee members with too much motivation and enthusiasm. Nobody can keep up. The things that you have achieved, like having websites and the meetings that you're having, the awareness you're doing in the community, it's all fantastic work, and I think everybody should be proud of the group as it stands. The membership, when we first set it up, the questionnaires we sent out, the feedback we got back from patients was that about a third of patients would like to be involved in a group. Now, obviously, we're not hitting that target, but I still think we should be really pleased with the membership that we do have. And what we're finding, and I'm sure Dave would agree, is a lot of patients lots of members do come back time after time, so they're obviously happy with what you're doing. One of the things I would say that I've noticed in the hospital is a lot of patients from Banbury do comment that it is too far to come. So one of my suggestions would be that the group thinks about a splinter group, so that you have a main group here in Oxfordshire and a committee, but that you maybe look for somebody who's enthusiastic to start a splinter group up in Banbury, where you might find you pull in a lot more members, and then you would still have annual general meetings where everybody meets together, but this other little group would meet separately throughout the year. I know in High Wycombe they do have splinter groups and it works really successfully, so my suggestion would be to think about that for the future.
Question 2 under this heading is Prostate Cancer UK has stated that prostate cancer still has a much lower profile in the public consciousness than any other forms of cancer. Despite its prevalence, why do you think this is the case?
That's a very good and fairly easy to answer question, Dave. The reason, I think, is because it doesn't garner such a high profile as, for example, breast cancer or another very prevalent cancer, because it is seen to be a disease of the older age group. That's one reason. Another reason is because it's men only, and men are notoriously bad at seeking help for symptoms. For example, they tend to put up with them for a long time and then realise it's too late. And thirdly, the prostate is in a hidden and slightly embarrassing part of the body, and we are just beginning the journey really to change the culture to get the younger men willing to talk about their symptoms and present to doctors about this. And I think the older generation probably still struggle. So it may take several more years before it achieves such a high profile as, say, breast cancer has with women who tend to present 15, 20 years younger on average.
We often hear there are new treatments for prostate cancer just over the horizon, but what are your predictions for the range of treatments that may be available in 5 years' time? Or about the many recent developments in cancer research facilities that we have read about in Oxford and the Churchill?
Thanks. There's another nice medical question. I think probably we're going to get a better marker than PSA, which has its problems. A lot of men who have a normal PSA have cancer, and a lot of men even more men who have an abnormal PSA don't have cancer, end up getting a biopsy, which they might not have needed. So we need a better marker, more sensitive and specific for cancer. Maybe even a urinary marker will turn out rather than a blood marker. We'll be looking more towards doing MRIs before conducting biopsies, I think, and the technology of the MRI is improving, so that we may then be directing our biopsies specifically at MRI abnormalities in the prostate, rather than just systematically and randomly sampling the prostate gland. Thirdly, I think we're going to be treating more cancers with focal therapy rather than treating the entire gland, either by removing it or by radiating it. I think we might be in a position where we can localize a cancer to one part of the prostate, or maybe up to a half of the prostate, and then just treat that half with some ablative technique like heating or freezing, and this could spare side effects. And finally, I was thinking, even now we're seeing 2 or 3 new drugs on the market that are amazingly clever and are treating what we call castrate-resistant disease, which is the type of disease where hormone therapy is no longer working, and men have hitherto been on a rather slippery slope. And now we're seeing such drugs like enzalutamide and abiraterone being looked at by NICE, and there are a whole raft of new drugs just coming along behind them as well. They're going to cost a lot of money, that's one of the problems, but they do work when everything else has failed, and this can buy men months and hopefully years of more life.
The advisability and the effects of the long-term use of tamsulosin.
Back to tamsulosin. Side effects, it can cause giddiness in a few patients, particularly elderly ones, and it can cause retrograde ejaculation quite commonly, which means that younger men don't like it, and if they're trying to have babies, they shouldn't be taking it at all.
Is the level for Zoladex in the body crucial, dependent on body mass, metabolic rate, etc.? Presumably, for the 3-monthly periodic treatment, the level will rise fairly quickly on implant, and towards the end of the 3-month period, it would have tailed away. The new 3-monthly implant, on top of the old implant, will boost significantly an already but decaying therapeutic level in the system. Is this likely to cause problems to some patients?
No, I think this question comes from a slight misunderstanding about the way that Zoladex works. Zoladex and other LH-RH analogues, as they're called, there's another one called decapeptyl and another one called Prostate. They all work the same way, and they work on the pituitary gland, which is a small sort of hazelnut-sized part of the brain, and so and that doesn't tend to vary in different people. So the Zoladex turns the pituitary gland's stimulation of the male hormone production off, and it's regardless of how big the man is, because his pituitary gland is still switched off from making the testicles make the male hormone.
Is there any evidence to show that having a vasectomy increases one's chances of contracting prostate cancer?
No, it was once suggested by an Italian group that vasectomy may be a risk factor for prostate cancer, but there were 2 very large studies done in the States which refuted it, and no one believes it because there's no real pathophysiological explanation for it anyway.
There is still controversy in some quarters about the PSA test. Do you personally have reservations about its use as a first indicator or of possible prostate problems?
I do have I do have some reservations because of the issue with the false negatives and the false positives. So we can't reassure someone who has a normal PSA, and we end up often biopsying someone who has an abnormal PSA when they don't have cancer. So there are problems with it. The thing is that in something like 20 years of routine clinical use, nothing as yet has bettered it in terms of either diagnosis or monitoring. There are a number of urinary markers coming along which may prove to be more specific for prostate cancer. So if the ideal marker is something that doesn't have false negatives and doesn't have false positives, and that's really what we're seeking.
How is the effectiveness of whatever treatment is given determined? Can scans determine if cancer cells have been eliminated, or is it just down to the PSA level monitoring, which is said to be a guide but not always reliable? Is a post-treatment biopsy ever considered? If it is down to PSA monitoring, is this for life?
So PSA, whilst it has its problems on the diagnostic side, it is an excellent marker for monitoring disease after treatment, especially if the prostate is gone. So it's very sensitive. If it starts to go up, then one knows that there must be some disease going on. The problem is we don't know necessarily where that disease is, and this is where some new technologies such as PET scanning may come in useful, because say a patient who's had a radical prostatectomy or a patient who's had radical radiotherapy starts getting a rising PSA, we don't know if it's in their lymph nodes or if it's in their bones or if it's just where the prostate is or was. We don't know that, and so sometimes we do end up biopsying a lymph node if it's slightly swollen on an MRI scan, but the PET scanning technology that's coming along, where they're using radioisotopes that home in on dividing cells, is looking very promising. And we don't tend to biopsy men who've had radical prostatectomies. If their PSA is rising very, very slowly, we usually assume it's local and recommend a course of radiotherapy.
The next question is also close to many of us, which is about incontinence. Some of our members who have had radical prostatectomies experience varying degrees of incontinence in the years after the operation. What advice do you give about possible treatments or ways to manage this problem?
This is one of the most unpleasant side effects of radical prostatectomy, and we do our best to minimise the effect of surgery on the pelvic floor by pre-treating or pre-teaching our patients pelvic floor exercises that, by an expert physiotherapist, and we encourage them to do exercises for 6 months post-operatively after the catheter is removed. And thankfully, the majority get dry or virtually dry, but not everyone. Those that don't get dry after 6 months, we will offer some form of treatment to, and it depends on the degree of the incontinence as to what we offer. If it's associated with urgency, then we can treat them medically, and if it's not associated with urgency, then we tend to assess pad usage and treat either with bulking injections if the pad usage is low, or if the pad usage is higher. Bulking injections, which is a day case procedure, don't work very well, so we'll tend to recommend a male urethral sling or an artificial urinary sphincter, which is quite a complicated major procedure. So a urinary sphincter is where there's an inflated cuff around the urethra below where the prostate was. There's a reservoir in the inside the groin, and there's a pump, a pump that you can activate the cuff and empty it out, which is located in the scrotum. So if you activate the pump, the cuff empties into the reservoir, and the guy can have a pee, and then by a sort of an elasticated mechanism in the reservoir, the water then goes back into the cuff and slowly compresses the urethra again to dry up.
The next question is on diet. Often we talk about diet, you know, what is the best thing for us to eat. There are foods that seem to prevent various cancers returning. A number of us here this evening have read and absorbed the Prostate Care Cookbook, and I wondered what aspects of the diet should we concentrate on? What food and supplements should we eat more of, and what foodstuffs should we avoid?
Thanks, Dave. I haven't actually read this book, but it looks absolutely fantastic. It's got some super-looking recipes in it, and then after each recipe, it says what the good thing is that's or good things in each dish. So I have to say, there's no really good hard evidence for changing your diet. There's quite a lot of evidence based on laboratory studies and large population studies, which have suggested, for example, that oily fish must be very good because Eskimos don't get much prostate cancer and they eat a lot of oily fish. The Oriental diet must be good because Chinese people and Japanese people living in Japan don't get very much prostate cancer, and yet when they move over to the States, they get a lot of prostate cancer. So something in their diet, maybe soya, is very good, and the Western diet, in inverted commas, which perhaps is a lot of char-broiled fatty meat and this kind of stuff, is thought to be bad. But actually, then there was a big study that looked at whether eating red meat caused more prostate cancer, and they couldn't find an association. So it's all a bit, you know, I wouldn't want to tell a patient that they mustn't ever have a nice bit of steak if they love steak, because there's no evidence to really base that on. Legumes are thought to be very good because they've got antioxidants, and cooked tomatoes have a substance called lycopene. Red wine has something called quercetin, which is also, like that one, also an antioxidant. Flaxseed and green tea may not appeal to everyone, but they contain some very good sort of sulforaphanes, I think they're called, with anti-cancer properties. And there is a nice study that showed that drinking about 8 glasses of pomegranate juice every day slows your PSA rate down if you're relapsing following a radical treatment. And that was a randomized study. So that's probably the only one that I would say, yes, really, if you've got a rising PSA after your prostate cancer treatment, get onto that pomegranate juice.
Just 2 questions left, really, and sort of fairly quick questions. Do you read the Daily Mail? If so, do you imagine yourself being out of work with all of the new wonder drugs becoming available?
I do sometimes read the Daily Mail because patients tell me, have I seen this article? And I usually end up going and reading it. I do often wonder why some doctors and scientists go to the Daily Mail to report their studies rather than publishing them in peer-reviewed journals. But that's the skeptic in me. I don't think I'm going to be out of work. I don't think Rose is going to be out of work. I mean, hopefully prostate cancer mortality will drop and it will become a managed disease rather than a killer disease. But to be honest, we've got an awful lot of other stuff to do in urology. You should see what comes in through the door on take.
We're almost at the final stage, and there once was a programme called Your Life in Their Hands. Many of us here put their life in the hands of you and your team. And we're eternally grateful, grateful for what we did. When you go home from the hospital, are you able to switch off? Do you have any hobbies or interests that enable you to close out the events of the day?
I expect you all know that I do have children as well, so I am kept busy at work and when I get home from work. But the things I like to do to relax, I love walking, I love being in the mountains, I love fresh air. I think that's important time, gives you thinking time, so that's what I like to do. The most important thing for me and for my well-being is my family and friends, and that's the thing that's the most important thing in my life, and that's the sort of thing I'd want to hold on to and what I cherish, really. So I do get some downtime, not very much, wish I had more, but I love the job, and I really enjoy working with Simon. I love being part of the support group.
I thoroughly enjoy dealing with you patients, and Rose is a brilliant colleague, and we've got Professor Hamdi and a lot of junior doctors and other nurses as well in the hospital, as well as our MDT, which is the radiologist, the pathologist, the oncologists, and so on. Out of work, I'm also a dad. I spend a lot of time running my girls to swimming pools around the city in the evenings and early mornings, and I do exercise. I think exercise is really important for general health, as well as there is some evidence to suggest it has an inhibitory effect on cancer, including prostate cancer. There's some very interesting papers published about that. So exercising 3 times a week, I think, is very good. 2 or 3 hours a week minimum really does make a difference in terms of demographics of cancer. And I also enjoy music, and I enjoy teaching medical students.